20% ఉంది. మరి ఏం చేస్తాము? కాదు, అది క్వశ్చన్స్ 1 hour ఉంది, from 5 to 6. ఇదా?
Refresh every time because it's every few minutes, sir.
So all the doctors are already registered.
And every 5 minutes ఒకసారి refresh
30 people already online. Bangalore, Anantapur, Vijayawada, Tirupati.
అట్లా ఇది పుల్ చేయండి, ఇట్లా రిఫ్రెష్ చేసి పుల్ సరే రిఫ్రెష్ అప్పుడు ఇక్కడ కూడా ఐ థింక్ కమెంట్స్ క్వైరీస్ ఇక్కడ ఇఫ్ యు వాంట్ ఇది టిల్ట్ చేయండి సో దట్ ఇట్ ఇస్
the full question. You are about to finish your data balance recharge with that.
1 GB.
Main దీంట్లోనే I think this will be the.
మీరు వైఫై కనెక్ట్ చేసుకోండి, నాట్ స్టార్ట్.
లేదు, that 4G ఉంది. No issues.
చేసి ఉంటారా? చేసి స్క్రీన్ ఎట్లా చేయాలి చూపించాలా? చెప్పాలా? ఇద్దా
Video, I don't know, pointless. And you can't even see.
Am I audible?
Yeah.
Yeah, you're audible.
Yeah, Samir, the slides you are ready, is it?
Yeah, the slides are ready with me. You want to have
not clear.
run through the slide? I can do it.
Make sure that it's running, that's all.
Siddha sir, you want to try the share screen?
Yeah, Mr. Jignesh, can you just stop sharing? I'll just run through both the slides.
Okay.
So this is the slide of acute coronary syndrome. So I'll just run the slide for Dr. B.K. Raghunandan.
The audio is not clear, Mr. Samir.
Dr. Raghunandan, can you see the slides?
Raghunandan sir.
No,
sir?
no, not yet.
Raghunandan sir, your bandwidth is low. Are you connected with a phone network or a Wi-Fi?
Wi-Fi,
Okay.
but Wi-Fi. What? I can see it now.
Okay, I'll just run through the slides.
Okay. Next. Next. Okay. Okay.
Okay,
Okay.
I'll just now clear
Perfect.
the acute shortness of breath.
Ishwar. Just be here somewhere.
This is Dr. Sridhar.
Yeah. Samir, tell me. Yeah. Yeah.
I'll
Go
just
ahead with
run
that.
through the slides.
Yeah. Yeah. Go ahead.
That's okay.
Okay. Okay. No problem. Go ahead. Yes.
Sir, we will start in 5 minutes.
Okay.
What about Dr.
they-
Sri's CV slide? I didn't see that.
Hello. Yeah. Tell.
Yeah, I'll just show the slides, CV slides.
Dr. Sridhar's CV slide from Apollo, Hyderabad.
Yeah, I'll just do it.
Yeah.
That's Dr. Sridhar Pedi's CV slide.
Yeah, good. Good.
Okay.
Okay.
Yeah, thank you.
So we keep logged in, or
Yeah, I think we'll start in the next 5 minutes.
okay. Okay.
Samir, you're able to hear me
Yeah, absolutely clearly.
clearly. Okay. Once we finish with these meetings, I think, you should take those good ones. I think you're doing this across India, right?
Yeah.
And I think you should take up those really good questions and put them as FAQs and spread the word among the physicians and general practitioners as well.
Yeah.
Because this is going to be a good learning experience for everyone,
Sure.
and including all of us. And I think this will be a real good program which will be carried forward by Zydus.
Sure, we'll do it. Thank you. Thanks for the valuable
Already
feedback.
and
And now that
no, thank you.
a lot of speakers, I guess.
Yeah.
I think when the speaker when they are presenting, so keep everybody is a mute, because it's the disturbance for the any other. I think
Yeah,
Samir.
that's Mr. Jignesh from the technical team. He'll ensure that everybody's
Yeah. Yeah.
Only the speaker should be on, all others on mute.
Yeah.
Okay?
all others will be on mute.
Even the viewers also, I think they will ask a question in between. You tell them everyone once the session over, and then that time the discussion part. That time they can have all the speakers can audio can be
No, the delegates cannot speak. They will be having a dialogue box and they'll be typing
Okay,
the
okay.
question and that will be transferred
Okay,
to
okay.
Dr. T.K. Venkatesh.
Okay, okay, right, no problem.
Samir, Lokesh is also on the program?
Yeah, he should be also logged in.
Okay, fine.
You want any message to be given to him?
No, nothing. Just out of curiosity. That's it.
Okay.
So first, Dr. Venkatesh should be speaking or Samir?
I'll just give a preamble and then I'll introduce
Okay.
Dr. T.K. Venkatesh and then he'll take
Okay.
over.
Okay.
In 2 or 3 minutes, we'll start.
Sure, sure.
Jago, volume తగ్గించు కొంచెం ఇదా పెంచడం ఇదా రైట్ తగ్గించు ఓకే 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 యా అండ్ వీడియో ఎక్కడ యా రైట్ ఏ యా ఇది
Samir sir,
Yes, Mr. Jignesh.
sir, we can go now live now. Start.
Sure.
You are go.
A very good evening to all distinguished colleagues.
just wait. Raghunandan sir has to come.
I'm Dr. Samir Muchala, heading the medical affairs for the cardiodiabetology therapy area at Zydus Healthcare Limited. At the outset, I'm sure you and your beloved
Samir, you're not audible.
Samir sir,
focus on ACS management
Yeah.
and acute shortness of breath. We have with us
Can you use
today,
the headphone?
sorry. We have with us today Dr. T.K. Venkatesh, the moderator for the evening, who actually needs no introduction. Dr. Professor T.K. Venkatesh is a consultant interventional cardiologist, Apollo Hospital, Bangalore. He is a former faculty member, Sri Devraj URS Medical College, Kolar, Associate International Member of the Society of Cardiovascular Interventions, Member European Association of Cardiovascular Interventions, Member European Association of Acute Cardiovascular Care, and he has several publications in international and other journals to his credit. May I request Dr. T.K. Venkatesh to take the academic proceedings forward and introduce the speakers, Dr. B.K. Raghunandan, followed by Dr. Sridhar Padi. Over to you, Dr. T.K. Venkatesh.
Thank you, Dr. Samir, for those kind words of introduction. And today's program is a very exciting one and basically relates to acute coronary syndrome in these COVID-19 times, very testing times for all of us. So to carry this program further, we have our esteemed speakers, Dr. B.K. Raghunandan, who is a consultant interventional cardiologist at Sadar Hospital, Bangalore. And he's been a former consultant cardiologist at BMJ Hospital. He's a recipient of award for Muniswamappa Memorial Best Paper in Karnataka CSI Conference, 2006 for the study, assessment of ventricular dyssynchrony in heart failure by tissue Doppler imaging and ECG QRS duration. And I think the next speaker will be Dr. Sridhar Reddy, and he's a senior consultant and interventional cardiologist at Apollo Hospital, Hyderabad. So we will have Dr. Raghunandan do the honors first, and then I think immediately after that, Dr. Sridhar Reddy will come over. I'm sorry for pronouncing this differently. I would stick to saying Dr. Sridhar from Apollo Hospital,
No problem.
Hyderabad. Yeah. So
Thank you for the kind introduction, sir.
you can start the deliberations.
Thank you for the kind introduction, sir. Welcome you all for this evening's discussion on ACS management in the current scenario with the background of the COVID-19. Management of acute coronary syndrome itself has been a big challenge over the years. And with the present scenario, I think the challenges are much more. If you look at the Indian perspective itself, next slide, ACS is an important cause of mortality in India, which we have known very well over the last so many years. It has become one of the major cause of mortality and morbidity among non-communicable diseases in India. Even in hospitalized patients, if you look at the MI, the mortality rate is as high as almost about 15%. Next slide. So today's focus on the discussion, as I already mentioned, is managing the ACS in the changing dynamics in the present COVID-19 scenario. Next. So what has been the impact of this COVID-19 on ACS presentation? One of the things we all have noticed, and I'm sure most of you who have been practicing cardiology in the last so many years would have suddenly seen there's been a change in the number of ST elevation MIs we are getting into our hospitals. If you look at the Western countries to the Indian scenario, whether it's Milan, Madrid, Massachusetts, all the world over, there have been a sudden drop in the number of STEMI cases, estimated to almost about 70%. Looks like people are more terrified now and they stay back home, even though they have symptoms and don't show up in the emergency department, which is very worrying for all of us. The interventional cardiology group in Spanish Society of Cardiology recently published a paper that shows that this drop in the STEMI numbers is almost the tune of 40%. And George Washington University Hospital had just 2 or 3 STEMI cases in the last 3 weeks, which is much less than what they used to see earlier. So basically what it has happened is people are now scared to come to hospitals because of the worry of the COVID-19, and the people who really need treatment are not reaching the hospital. One other thing that is happening is the STEMI mimics. So what has been the impact on the ACS because of this COVID-19? Primarily, one of the things we realize is it's a viral disease, and troponin elevation in viral myocarditis is very well known, and it presents like an acute MI. And when some people have undergone angiogram, they're found to have no obstructive disease in them. So something like what we normally used to see as a Takotsubo cardiomyopathy or a stress cardiomyopathy with some spontaneous coronary dissection, those are the kind of cases which actually have mimicked the STEMIs, and these are the cases that we are seeing more often now. So observation has clearly made there's a drop in the true STEMIs and an increase in the STEMI mimics, which is based on anecdotal information. But the big question being asked is, where have all the heart attacks gone? Next. So if you look at the impact in terms of the numbers, there's a study from Spain where they saw 71 STEMI patient hospital network. They saw the reduction of diagnostic procedures by 57% in the cath lab, reduction of elective PCS by 48%, reduction of structural intervention by 81%, which is understandable because you wouldn't want to do elective structural intervention in this situation, rather, would want the patient to wait, and reduction in the primary PCI by 40%. So this is a big drop because now we are probably going back to the times when we used to thrombolyze patients first and then take them for elective PCI. So they also noted that there's a slight increase in the use of thrombolysis due to problems in reaching the hospital, the transport being a major issue. Next slide. So what are the dynamics that change in the current scenario? One, delayed attention due to lockdown because people did not want to go to hospital immediately because there were logistic issues. One is the patient factor. One is the limited and lack of transportation I already mentioned, which is true world over, not just India. Patients should be made aware of the nearest healthcare facility. See, that is one more thing. The patient wouldn't know which of the hospitals are working still towards catering to these non-COVID patients. So that is one of the places where people need to actually find out where they could go. Next is the healthcare factor, because now the whole of the healthcare focus and the energy is being towards the COVID-19 prevention and treating those patients. Other things have actually taken a backseat. So minimal or lack of routine medical services, fear of infection, which is again a biggest scare, staff sickness, because a lot of healthcare professions are getting sick because of the COVID-19, and triage and prioritization, like which of these cases that need to be prioritized. That is one more thing which is actually, being a big issue here, which is the Cardiology Society of India has actually noted recently. The next slide. So if you look at the Sky ELM recent guidelines that came in for consideration of cardiac cath lab procedures during a pandemic, some of the things have told us about the guiding principles for confirmed or suspected patients with COVID-19, screening of patients prior to doing a cath in these patients, and using the personal protective equipment for healthcare providers is a very important thing. And then managing the hospital and cath lab personnel so that you don't expose too many of them to the COVID-19 or any of the diseases that we are looking at now. And contingency planning, where you have to make sure you have enough staff to continue doing the work in the cath lab. And of course, most important, how to select those patients. We look at all these one by one. The next slide. So first is at the emergency department. All STEMI patients initially undergo clinical and screening for the COVID-19 or contagion evaluation. Currently, all STEMI patients should be brought to cath lab for primary PCI is what we've all been following for the last recent many years. But fibrinolytic therapy probably will now be advisable if the prevalence of the contagion of COVID-19 is high or the system resources are in danger of becoming overwhelmed. So probably we have to change our strategy from being aggressive, invasive to probably initially go conservative with fibrinolytic therapy and then take those patients whenever we have the resources to do a PCI for these when required. Next, as the prevalence of the contagion increases, I think just go back to the previous slide. As the prevalence of the contagion increases, causing systematic and infrastructural bottlenecks for care, especially given the regional variations, the primary therapeutic option may have to change. This is what is one of the big things that has happened in the COVID-19 scenario, where you had to change the options from being primarily where you look at PCI to probably look at fibrinolysis. Next. Alternative therapeutic options like the systemic fibrinolytic therapy may be considered in low risk ST elevation MI, like patients with inferior wall MI without right ventricular involvement or lateral wall MI without hemodynamic compromise, which indicate less of myocardial damage, depending on the local availability of the expertise. And one of the potential downsides of this is patients often require prolonged ICU level of care when you use conservative management, and this again may actually block some of the beds in the ICU where you need to actually minimize the stay in the ICU to help other patients to be kept there. And one of the things we can do, or one of the things that has been actually advocated, is try to do bedside procedures, IABP, pericarditis, ECMO, temporary pacemakers. These, wherever possible, have to be done so that you can actually try to conservatively manage them with the supportive care. Next slide. So this is a nice flow diagram that we are seeing, where you look at the patients as they're being distratified. If you look at a patient with an ST elevation MI, first look for the alternative causes. If you don't have any alternative cause and it's an ST elevation MI with less than 12 years from the attack, if it is not, then you initiate medical management, oxygen therapy. And then if it is a patient where there's no contraindications or thrombolysis, you can thrombolize in the ER. And if the thrombolysis is not successful, then you can consider these patients after doing a COVID-19 screening. And if there is a definite surety that you don't have a COVID-19 in these patients, you can admit them to the ICU and manage them further. Next slide. If the first one was about the STEMI patients, there's a slight change when you look at the unstable angina, unstable on NSTEMI patient, you dissatisfy them based on the usual GRACE and the TIMI scores. Then you do a screening for COVID-19. Then if you feel the potential risk of infection is low, initiate the medical management and then do the laboratory test for COVID-19. And if you find they're negative for COVID, then I think you should consider either an early invasive strategy if required, and admit them to ICU and then manage conservatively where the risk is low. Next slide. So PCI should only be performed to culprit vessel unless a non-culprit lesion is deemed unstable or multiple culprit lesions are present. This is something we have been generally following also in presence of ACS. And in patients with respiratory distress, early intubation should be considered in order to minimize the aerosolization of the viral particles, which is again some practical thing to do so that you prevent the spread and the contact. Single procedure room should be designated for care of patients with the contagion, airflow modified to negative pressure if possible, so that you minimize the spread and the contact. Next slide. Next slide, please. So fibrinolysis may be the best compromise of prompt reperfusion for patients with the least resource implications for the institution, buying time for a complete clinical picture to be made. So this is as recent as April 2020 from the circulation. So in this present scenario, probably reperfusion of STEMI, the fibrinolysis will be the first choice and not a primary PCI. Next. And screening of patients prior to cardiac cath. This is very important. One thing you should always follow in most of the hospitals as per the present guidelines, all elective surgeries, non-essential medical, surgical and dental procedures to be delayed so that you prevent the contact, prevent the spread, and you can safeguard your health professionals and keep the cath lab ready for the dire emergencies. Deferral minimizes the risk of exposure to the contagion for patients and staff. It maximizes availability of the inpatient beds in anticipation of a surge in hospitalization required for the COVID-19 infected patients. Next slide. So how do we actually protect ourselves? The healthcare provider should be using personal protective equipment, N95 respirators, protective eyewear, full face shields, disposable caps, gowns, surgical gloves, and shoe covers. So whatever has been prescribed for PPE should be strictly followed, because this is one thing that protects all of us from accidental exposure. And then, the hospital also will be left with enough personnel to manage other emergencies, because COVID will want a quarantine if any of them get an accident exposure by chance. These precautions serve to protect clinicians from airborne, droplet, and contact infected sources. Steps for donning and doffing PPE should be understood and taught in most hospitals. I'm sure all the demos are being done in hospitals world over, including India. Reduction in droplets spreading and optimization, negative pressure ventilation offers optimal protection, again, preventing spread and reducing the aerosolization. Next slide. Personnel management, this is what I've been saying. Older adults, people above the age of 65, people with chronic cardiac pulmonary disease or diabetes, hypertension, and similar diseases have very high risk of serious illnesses, because these are the patients who probably will go on to ventilator, develop pneumonia with respiratory failures, and mortality is high in this age group. Desirable to minimize the operators and staff with these conditions being from, so that you don't directly expose them, and to presume or confirm cases of contagion, you should not be exposing many of them. So probably all hospitals should have a policy of, using 50% of their staff at one point of time, so they all work in different time settings. Next slide. Again, patient selection is very important. So decrease exposure as low as reasonably achievable to the patients with the contagion. So make sure that you first deselect rather than select a patient. A subset of patients should be considered deferral for urgent diagnostic intervention procedure in the cath lab, rather than trying to be over enthusiastic. The kind of patients whom probably you can defer are STEMI patients with severe pneumonia who should undergo conservative treatment, which includes fibrinolytic therapy, because these are the patients who probably are COVID positive sometimes. And NST ACS with low risk features can be always stabilized with medical therapy. We not rush and do PCI in these patients. Type 2 MI or myocardial injury with elevated troponin related to sepsis or ARDS, which again would not be due to coronary lesions, which do not need an urgent cath. Troponin positive myocarditis without cardiogenic shock. There again, the cause could be the COVID-19. Elective cardiac, structural, and vascular diagnostic procedures or intervention with stable non-life-threatening symptoms, or can be managed conservatively, and then we can plan further when the situation gets better. Next slide. Similar recommendations have come from the Italian Society of Intervention Cardiology when they presented their position paper. So whatever I have told now is mainly to go conservative in most of these patients in the present scenario, and only when there's a dire need, when the patient really needs a cath, to just go ahead begin taking all the precautions. Next slide. So decreasing exposure as low as reasonably achievable to keep all personnel as safe possible. This is one of the most important things that we need to do now. And the key elements should be rescheduling all non-urgent and elective procedures, careful patient selection for urgent and emergent procedures with recognition of potential shift in risk-benefit ratio in a setting of a highly contagious virus like COVID-19, meticulous donning and doffing of the PPE, which again is very important for personal protection, performance of bedside procedures when possible rather than going to the cath lab, where you tend to expose more and more people, and risk our hospital resources to be reduced. Staffing modifications to limit infectivity and preserve staff availability again goes hand in hand with the same advice. Next slide. So a few take-home messages for all of us. For acute myocardial infection patients with COVID-19, a multidisciplinary approach is very important. You should involve the ICU, you should involve the emergency doctors, you should involve your pulmonologist. Everybody should put in their might to first look at the patient's safety, and the hospital also should have its own priorities. Emergency intravenous thrombolysis should be the first choice for management of STEMI. If thrombolytic therapy is contraindicated for any reason, like a recent surgery or intracranial hemorrhage, refer them to the local designated infectious medical institution. For NSTEMI, treatment strategies should be based on the GRACE risk score stratification while awaiting results of the novel coronavirus nucleic acid detection. So if you find it negative, then probably if the risk score is high, you can think of an invasive strategy. Otherwise, in these patients, a conservative strategy should be the first thing to do.
Thank you, Dr. Nandan. That was good.
Yeah. Thank you, sir. I would just say the main thing what we need to remember is COVID-19 is going to be with us for many more months, and world over, it has still been very active. So our approach now should be both a doctor's safety and the patient safety. Thank you.
Rightly said, rightly said. Yes. I think that should be the message that we should always remember. And the patient care also is very important. And I think we'll have the questions at the end of the session. We will request Dr. Sridhar to come on and give his presentation.
Okay.
That once that's done, then
Yeah.
we can
Thank
do the questions.
you, Venkatesh sir. Uh, Thank you, Venkatesh sir. Thank you, Raghunanda sir. And thank you, Samir. And also, JDS people. In the lockdown situation, you people are doing the very good seminars. And now everybody is panic all over the world because of the COVID. And everywhere we are getting the cases. And Raghunanda sir, actually, you given a nice presentation. And the last 3-4 days before also, we had acute MI case. So we thrombolized the case.
Yeah, that's the right approach.
Yes, sir. Actually, now tomorrow we are going to do the, but COVID, we did the COVID test. It's negative, sir.
Negative.
Yeah. So thank you, sir. Now we are going to the management of shortness of breath. So many patients coming with a asymptomatic symptom nowadays. So earlier, before 2 weeks before, patient will have all the symptoms of fever, high grade, temperature. But now asymptomatic patients are increasing more. So that's why even mild breathlessness also, everybody is panic. Now, what is the cause, most common cause of breathlessness according to the cardiac related with the COVID? So we say most of the time, so the dyspnea commonest symptom, even whether it's a respiratory or cardiac, 90% the symptom is dyspnea, is shortness of breath. So we observed many patients nowadays with the, even you saw the this swine flu is a main because of the similar symptoms, I think, like swine flu and also this corona. We saw in even dengue also, we got so many cases cardiac related myocarditis, even swine flu also. So it is cardiogenic shock and pulmonary embolism. That's why all over the world, everybody is thinking about the plasma transfusions and now stem cell transfusions. I think now present situation scenario, we are all should know dyspnea. Now we are going to a small presentation about the dyspnea is a common symptom affecting 25% of the people, ambulatory settings. Overlap with the clinical presentations of the comorbid disease, congestive heart failure, chronic obstructive pulmonary disease. I can make the diagnostic evaluation of dyspnea in the clinical knowledge. Next slide, please. The cause of acute dyspnea mainly respiratory, cardiovascular, neuromuscular, systemic, psychogenic. But you know, many of them know all the things. So the most common now, according to this scenario, is a cardiovascular, respiratory. Because in the cardiovascular, mainly because of the patient will come to the emergency with it may be non-ST elevation MI, ST elevation MI, pulmonary embolism, and valvular heart disease, and pulmonary hypertension. And this scenario, patient sometimes even acute MI patient come with the 2-3 days before patient has a fever. That you know because of the post MI patient has a fever. So everybody getting panic. Even patient will come to the emergency. Everybody emergency physician first thinking about corona related only, because we want to whether to go for the medical management or whatever the things, whatever Raghunandar sir told. So first thing is you have to go for the examination, see the saturation, see the symptoms, see the ECG, see the echo and all those things, then come to the conclusion. But don't neglect our old patients also, the corona positive. Okay, same like a respiratory patient will come with the COPD patients, pneumonia, pulmonary embolism and lung, some CA cancers, pneumothorax. Commonest bronchitis, asthma patient will come. These are the commonest cause of acute dyspnea. And neuromuscular, systemic, psychogenic, all the things, I think we'll leave it. Next slide, please. The importance of the shortness of breath current scenario is dyspnea is a high risk symptom. Patient suspected with a myocardial infarction, just now I told in the ambulance. And patients suspected MI presenting with a dyspnea has a significantly higher short and long-term mortality than patient with a chest pain, irrespective of the confirmed myocarditis. Because most of the times they will go for the acute LVF, LV dysfunctions that may precipitate to the sudden onset of the dyspnea. Next, go ahead. Next slide, please. Yeah, if you see the importance of shortness of breath in the current scenario, so see the chest pain. Chest pain will be continuously persistent, so years long will be there, and the dyspnea slowly is progressive. According to the Kaplan curves, cumulative mortality with patients suspected with myocardial infarction used by the electrocardiogram based on the telemedicines, and you can see the curve how with the dyspnea and the chest pain. Next slide, please. Now, the approach to the dyspnea in the current situation, whether the patient is a COVID or non, earlier I told you COVID and non-COVID related, and associated with the fever, dyspnea, cough. So just see, if the patient will come with acute MI, patient fever won't be there in the sudden onset. It may be there, that is called Dressler syndrome. I heard everybody learned in MBBS, we had a Dressler syndrome, like a, so it will affect after 1 or 2 days after the patient will have the fever also. Dyspnea will be there, pericarditis will be there. And cough always with suspicion with acute LVF, myocarditis also. Any viral myocarditis, or sometimes fever with cardiomyopathy patients, they will have the infections as to with other non-COVID related patients. So that's why people always, in emergency physician, you have to see, you have to think broad-minded. Go with the COVID and non-COVID conditions. So, but every patient don't think about the COVID, only COVID related. Always people come emergency to the non-COVID also. Next slide, please. So importance of the shortness of breath current scenario, everybody knows. Now everybody, if you are going to the outside also, you are going to some other place, you have to go in the, somebody will tell, oh, this fellow came from the other country, this fellow comes in the apartment also, people are afraid. Somebody is staying in the apartments and they'll tell, this fellow came from New Zealand, this fellow came from USA and other things. So totally, even nowadays, even the doctors are, they're not allowing to the apartments because this fellow like that. So you have to think about all the history. Everybody knows this fever, cough, sore throat and breathlessness and quarantine last 14 days. All the questions will be there. Next slide, please. Importance of shortness of the current scenario in the symptoms with the demographic, that the age related, all those places where you traveled, symptoms of the patients, whether the patient is suffering from fever, cough, difficulty in breathing, and the same like a foreign country, like a quarantine, all those things will be there. You have to know about emergency physicians, you have to know all those things. Next slide, please. So, which lung or heart, both are equal. Whether the patient is going to be cardiogenic shock, is related to cardiac, and people are going to pulmonary embolism, they will tell lung. So both are equal. So patient, everything is cause of death is related to cardiac arrest. People will tell not a cardiac arrest. Everybody, even cancer patients are going to cardiac arrest because many people and common man they will tell because of the cardiac arrest. So next thing is next slide, please. Yeah, inflammation of the heart. So this all everybody knows how the inflammation responses, like inflammatory response to autoimmune disturbance, autonomic tone disturbances, and hypercoagulable states, anemia. Now everybody telling hypercoagulable states regarding the pulmonary embolism, cause of the death, and also decrease the cardiac pulmonary functions, hypoxia. These next thing is both will cause myocardial injury and conduction disturbances. So there is going to the hypotension, myocarditis, and heart failure, and also tachyarrhythmias and bradyarrhythmias. So now the most common, now everybody every day 1 or 2 calls will come, sir, can I take SCQ tablet? Because I tell all patients better to take ECG. Don't take unnecessary. Somebody will tell. Even Trump also told first day immediately start to SCQ. First thing is don't tell the patients that everybody start to SCQ, because SCQ again QT prolongation will be there. We have to tell every patient that they have to take the ECG, ask them to WhatsApp the ECG, and then you can only for the healthcare persons. So that's why the QT prolongation will be there, and that also causes sudden cardiac deaths. So be careful for everybody to advise for ECGs. Next, go ahead. Next slide, please. The fulminant myocarditis. This one case reported by our China virus. Trump told already China virus. So no, don't tell about COVID. It's a China virus only. So the first case reported a 60 years fellow patient had a myocarditis with heart failure. He expired after 33 days. He stayed in the emergency and he recovered. So first, initially we saw many patients. The first case. Next slide, please. Next, I will tell the case scenario. Next slide, please. Next slide, please. Real life case. Yeah, this patient, first case of COVID complicated in the fulminant myocarditis, reported in the month of, it is reported in the China. Okay. This 63-year-old gentleman is admitted with shortness of breath, expectoration with the sticky sputum. Temperature is around 40 degrees centigrade, and chest tightness and active, and no history of any heart disease or hypertension, allergic cough for 5 years, and previous history of smoking. Next slide, please. So this blood gas analysis shows pH was around 7, less than, it's supposed to normal 7.4, it is 7 only. PCO2 is high, normal PCO2 is 40, now it is 76. PO2 normally 99 to 98, but now it is here, PO2 is 66%, saturation is only, but saturation is 90%. But if you see the PO2 and the SaO2 is, first always PO2 is important in ABG blood gas analysis. Troponin, your troponin also is elevated. Normally up to, we can take it up to 3 to 4, and also diffuse in that echocardiogram it shows decreased myocardial dyskinesia with decreased LVF. So most of the, even I saw earlier many people who had swine flu and even dengue, people developed myocarditis and LV dysfunctions. The even interleukins also it's increased. Next, bedside chest X-ray goes ground glass appearance is indicator of viral pneumonia. Next slide, please. You can see the X-ray and the CT. Next slide, please. Yeah, ECG normally people will have the sinus tachycardia, non-specific HT changes are there. But sometimes I saw ECG who had myocarditis have a bit of non-ST elevation MI, ST COVID with the T inversion will be there. And even sometimes troponin is elevated. So always be careful whenever the patient will come with these scenarios, COVID with the cardiac related, always repeat the echo, repeat the troponin, repeat the ECG every day. Next slide, please. Here you can see the after admissions, the graph, the day after admissions, first A slide, you can see, and after the B slide, you can see in between it was first day it was increased myocardial things. Then next it is after the C, day after the admission slowly decreases. The number one myoglobin and NT-BNP troponin all are elevated. Next slide, please. Yeah, you can see the bedside echocardiogram done. So first the enlarged LV is enlarged, and LV ejection fraction was 32%. Pulmonary hypertension, mild pulmonary hypertension is there, mild to moderate, and they are not mentioned about the RA-RV dilatation. Maybe next slide, please. Yeah, here you can see the patient treatment regimen with the ventilator support, high oxygen flow, that retroviral therapy, ritonavir and lopinavir, interferons, and also methylprednisolone. Normally, we'll give for even swine flu, and some patient we given methylprednisolone, immunoglobulins, antibacterial tazobactam and piperacillin, and the CRRT. After the treatment, LV function was improved drastically, 68%. It was around 30 to 35%. Now it is 68% of the left ventricle, and the wall thickness and everything become normal. The infection-related markers increased gradually, and also 26 days of the septic shock, this DIC was there and gradually developed after that patient recovered. Next. And next, after 32nd day, patient expired with the patient died with the 33rd day of hospitalization. Before I thought it was there up to 32 days in the hospitalization. 33rd day here patient expired. Next slide, please. So now the first case, contagion complicated pulmonary myocarditis, the case report and insights. See that COVID present with the pulmonary myocarditis. The heart is the second target organ after the lungs. Not only present with abnormalities in markers of myocardial injury, but also structural and functional damage. So possibility the immune-related injury may be the main mechanism of myocardial injury associated with viral infections. So dyspnea, fever, and cough considered to be COVID-related unless proved otherwise. So most common cause of the death after the ARDS patient going to be septicemia, ARDS, and other things, myocarditis and cardiogenic shocks. But unfortunately, this next slide, please. So this patient not survived, and that's the main. The take-home message is, so always be careful whenever the patient will come with the COVID positive cases. So ECG, echo must, and also see the regular ECGs and also troponin levels. Sometimes interleukin is very costly, nobody is doing, and go for the pro-BNP and other things. Follow up the case, and don't think only it is only related with the pulmonologist, but cardiologist also main role in all the cases, even pulmonary embolism, all the cases generally we can see, and CT, HRCT, CT angiograms, all this we have to see. So thank you for all yours, and also thank you Venkatesh sir and Samir sir and Raghunandan sir.
Thank you, Dr. Sridhar, and thank you, Dr. Raghunandan.
Thank you, sir.
It was well done, and I think these difficult times you will be many a times wondering as to how to manage a patient of acute coronary syndrome with that uncertainty of COVID-19 looming large. And whenever you get a patient with a ST elevation MI, you'll always be wondering what to do next. So a good guideline which has been given to us after a large study from Milan, where they found that in their coronary angiograms with STEMI, 70% of the people had normal coronaries. So that was a indication that probably it's not the coronaries, but it's more of a myocarditis which is happening.
Yeah.
So why a PCI is basically because myocarditis is a possibility. And secondly, you just take a patient to the cath lab when you are suspecting a COVID-19. You are likely to use up your resources very fast. You are likely to infect the cath lab personnel. And suppose a patient has an event in the cath lab, and if you were to do a CPR or intubate, then a lot of aerosols are going to get produced. And when that happens, the chances of infection to you and to the surrounding personnel goes up. So the focus of the guidelines that have been released now has been more on thrombolysis. So we are kind of pushed about 20 to 30 years backwards, and we need to probably now go back and read what dosage, how much of thrombolytic therapy we need to give. And Dr. Raghunandan, a small question to you. What do you do in your hospital when you get a STEMI? Like what is the usual protocol you follow?
In the COVID scenario, we definitely follow whatever the present guidelines are saying. We always prefer to do a conservative management unless patient is in cardiogenic shock, where there's an absolute contraindication for thrombolysis. And even in those patients, we first ensure a COVID-19 screening is done for these patients because we don't want our cath lab personnel to be unnecessarily exposed.
No, would you want to thrombolyze these patients? Because now I'm
Absolutely.
sure COVID-19 tests are difficult to do. You don't have those.
Correct. Yeah. Now, I think slowly the rapid kits are available. We are in the process of procuring in our hospital. Yeah, like you said, the first option is always thrombolysis. So I think I said we might have gone back by 20 years, but one per reperfusion strategy which can be safely done in the present scenario is fibrinolytic therapy.
Right. So there are some questions that have been coming up online, and Dr. K.S. Shrikant Rao asked, what is common along with COVID, myocarditis, arrhythmia, or MI? COVID, can it cause MI? Is the question asked.
Sir, the chances, yeah, tell me, Raghunan, go ahead, sir.
No, you can go ahead, sir.
Go ahead, sir. Go ahead, sir.
Anyone. Yes, Dr. Raghunandan, tell me.
I think myocarditis is what has been more often reported. Like you already mentioned in the Milan study itself, when they took those patients, even with ST elevations and they found there was not much of the coronary involvement. It was more of a myocardial involvement that was causing troponin rise and LV dysfunction.
Okay. In that, you want to add something, Dr. Sridhar? Dr. Sridhar, would you want to add something?
Yes, sir. Whatever Raghunan sir told, myocarditis is more common, sir. Myocarditis is the most common cause of death and are related with other pulmonary embolism. I think we didn't see till now pulmonary embolism, but most of the times they in the Italy and other France they reported cases. I think, but I never across till now in India also so many patients had mortality, but till now nobody had mentioned about MI.
What do you think is the cause of myocarditis in COVID-19?
Sir, it's mainly because of the viral myocarditis. We don't know what is mainly because of the distal vasculation, microvasculation, and LV dysfunctions, dyskinesia, LV enlargement, hypotension, all those things.
Okay, I think most likely people say that one theory is that whether the virus directly affects the myocardium and causes viral myocarditis, but that
Yes,
is not supported in a very big way by various experts.
yes,
People talk about the virus attacking the RBCs, and once it gets into the RBCs, it's like carbon monoxide poisoning, they say, and it dissociates the heme from the globin, and the heme comes out, and so the oxygen carrying capacity of the blood goes down. And when
yes.
a lot of oxidative stress and cytokine storms and all that happen,
Yeah,
leading
all
to
the same like inflammation markers are all those mechanism is like other inflammatory markers is going to be the
correct. So I think with this myocarditis in your case, Dr. Sridhar,
yeah. Tell me, sir.
you did a wonderful case of fulminant myocarditis.
Yes, sir.
And in a case of myocarditis, what would you think would be the recovery pattern that you could look forward to? Do you think these patients are going to recover in the long term once they have myocarditis?
Sir, actually, we never come across because other I saw a patient with a swine flu and other people with any viral myocarditis. People recovered.
No, recover in the sense there are two parts to recovery. One is the lung part and the other is the cardiac part.
Yeah, that's why the cardiac part definitely will recover, sir. Mostly because of the lung part only. We have to take care of the ARDS part. If the ARDS part is improving, definitely myocarditis 100% is going to be improved, sir.
Yeah, correct. I would tend to agree to that, but then we don't still have the long-term implications of
Yes.
this COVID-19 would do to the heart once it
Yes.
affects the heart.
Yes, yes, sir.
When people do recover from myocarditis, the long run of it, is it going to behave like some kind of a cardiomyopathy and things like that is something which
same thing. Yeah, again, recurrent hospitalization, LVD functions, same like whatever you are telling, sir.
Correct. And Dr.
Even
Raghunath,
the case, tell me, sir.
Dr. Raghunandan, what do you think about arrhythmias in COVID-19? What do you think about arrhythmias? Because Dr. Srikant Rao was asking this question, whether COVID can cause arrhythmias.
Yeah, I think in the setting of a myocarditis, definitely arrhythmias are bound to be one of the factors that would result in sudden cardiac death. I think it has been reported also in many of the cases where myocarditis was found to be there in COVID. Yeah, definitely. I think arrhythmia is one of the things we have to keep in mind.
Tachyarrhythmias or bradyarrhythmias, which one do you think would be more common?
I think tachyarrhythmias will be more common.
Yeah, I tend to agree on that because most of the time, tachyarrhythmias is the one that usually is seen in myocarditis.
Yes,
Just one thing I want to add about the previous discussion on myocarditis, even in the case presented by Dr. Sridhar, the LV actually improved.
Yes, sir.
But then the mortality.
Yes, LV. Yeah, LV
some other
improved.
cause.
Yeah, LV improved. Up to it was 38 to time again it went to normal. Even TROP-I was and even interleukins, everything. But unexpectedly, I think patient because of the ARDS and not coming over the lung part, I think that may cause the.
Yeah, I think he died because of DIC. That's what.
Yes,
I think
DIC.
Where he died. Yeah, that's right.
Yes,
okay.
Yes.
So, I think one of the studies mentions that there is a 17% incidence of arrhythmias when you have COVID-19. There is a paper from Sweden, and that says 17% incidence of arrhythmias. Yeah.
Yes.
Okay, we go to the next question by Dr. Nagesh Naik from Davangere. He asks whether hydroxychloroquine is effective in its data or is it just hyped? So what do you think? Is it just hyped and everybody is taking hydroxychloroquine, or do you think there is some data behind it and it shouldn't be given just like that?
Yeah, the debate is still on, but there are no randomized control studies as of now to say the hydroxychloroquine has been proven right. There's a French study which actually found it to be not very useful very recently. So as a prophylactic, they said it may not be very useful, but there are studies, small studies, which have shown that it may reduce the viral load. It may not be curative, but it may probably reduce the severity of the progression of the disease.
You have anything else to add, Dr. Sridhar?
Sir, yeah, if it suppose people, everybody, even Apollo, all employees given hospital is given the free these things. So they are taking everyone. People are coming for taking the easy, and I think is they're taking, sir, because no harm. Only thing is we are giving weekly 2 tablets for an mg. I think if you take continuously, that's because those
QTC.
complications like QTC prolongation, other things. If you suppose something people know, one person will take in the hospital, some colleague will take, and he won't take, he will say, I didn't take. That psychologically, that.
No, I think
But
now,
I tell, sir, and till now we don't know the correct this thing, sir, because people mentioned other cases are it's good, is affected, all those things. That all those start their views and other things, then people are trying.
yeah,
But we don't know correctly, sir, till now how the.
correct. I agree on that, but as of now, the recommendations from ICMR has been that all healthcare workers,
Yes.
all
High risk
healthcare
groups.
workers, irrespective of they being a doctor or a nurse, whoever
Correct.
is likely to come in contact, is to be given a HCQ prophylaxis. And number two, the family members of patients who are in quarantine should also be given HCQ. If they are diabetics, if they're elderly people, more than 65 years of age,
Sir,
you should.
and sir, one this thing, because now people who had connectivity disorders, who had arthritis, even rheumatologists, they are taking so many years the HCQ tablets. But till now, nobody will come with any complication like acute prolongation, arrhythmias. So many rheumatologists, everybody they are writing. I think every alternate prescription for rheumatologists, they had a HCQ tablets.
So you think it's relatively safe to take, right? That's what
Yes,
you mean.
definitely, sir. Yeah, small dose.
I think
Those again.
it's a pretty safe
And
drug.
sir, one thing, and even azithromycin and both SCQ at a time is not good. The combination, sir.
That's what I was about to say.
QTC prolongation.
Azithromycin is also known to increase the QT interval.
Yes, azithromycin also.
It also increases the QT interval. So when you combine both azithromycin with hydroxychloroquine, the chance of all kinds of ventricular arrhythmias is going to become more. So hydroxychloroquine alone is considered to be pretty safe.
Yes.
And can be taken, but then always get a baseline ECG done.
Yes, that must. And people are taking beta blockers. Those people are, and the people sometimes taking any anti-arrhythmics like a Caldron. People they don't know. So those people we can advise.
Correct. If the QT interval is normal in the baseline, I think they're pretty safe enough to go ahead and get their
yes, sir.
taken. So I think the hydroxychloroquine as of now has not had any randomized controlled trials, but then people are taking that because it reduces the viral load, as Dr. Raghunandan clearly pointed out. And I think a lot of appreciation for the way the webinar is going. By the way, one more question is, what do you think is the role of steroids in myocarditis, Dr. Shriti?
I think is a good, sir. Many people generally come with most of the times we'll start small dose of steroids, sir.
No, like, are you selecting your patients for giving steroids, or do you think you need to give it to everyone?
Not everyone, sir. If patient will have some septicemia associated with any shock and sepsis related, and according to this, hypotensions, even with inotropic drugs, patient sometimes they won't improve the even all three inotropes like dobutamine, iodine, all those things, patient will come with a shock. Those patients, I think steroids is helpful in both conditions.
Right. And Dr. Raghunandan, I have a question for you. Suppose you thrombolize a patient as per the guidelines in ST elevation MI, and then subsequently you find that the thrombolysis has not been really effective, and you may be tempted to go for a rescue PCI in such situations. So what would be your approach on this? What would you be doing?
Yeah, we should probably go by the flow diagram I showed. Ensure first you screen them for the COVID-19, and then with all the PP and other precautions, you have to then probably subject the patient to a rescue PCI. So before we do the PCI, probably we need to make sure the screening is done. because this ensures
Yes.
safety of the personnel of the hospital, and
Yeah.
also make sure that we are taking care of ourselves.
We
Very
did.
rightly said.
Friday we had
Very,
admitted, sir. Friday patient had come with acute MI, and then we did our medical superintendent and everybody told this patient is stable that time. He was not in cardiac, not in LVM. That's why we sent the sample. We explained the patient attendance, everybody, because and we told if any are going to emergency, we are going to do the primary. That we can't. So we sent the sample, send the report came within 24 hours, more than 24 to 48 hours. We are getting the report, sir. Because the private hospitals are not allowing to do no, sir. We are sending the sample to government hospitals.
Correct.
That's the main problem.
that's right. And one important angle that we should not overlook is, please remember that in patients with COVID-19, you also have a lung component. Before you want to go
Yes.
beyond thrombolysis and take the patient to the cath
Yes.
lab, look at his lung condition.
Yeah,
If it is a
definitely, sir.
moderate,
Definitely.
if it's a moderate to severe respiratory problem, then you have to probably take the back seat. Let's say,
Yes.
for example, you have an inferior infarct or a lateral infarct,
Yeah.
right? A small infarct. Patient is hemodynamically stable. Then don't take these patients up for aggressive cath lab procedure.
True.
I would say manage them conservatively as much as possible.
Very
If
good.
a patient got a real lung problem, saturation is coming down, and he is dependent on the ventilator, etc., then in such circumstances, we back off. As cardiologists, we allow the respiratory team to manage, the intensivist to manage, and then probably defer your aggressive cath lab work. That's the way you want to do it. The
It
second
should
thing
be
is,
multidisciplinary.
suppose you are forced to do something to save the life of a patient. Let's say he's got a mild to moderate respiratory problem. Then in such circumstances, make sure to minimize aerosol release in the cath lab. You get the patient intubated first, right?
Correct.
And once you intubate the patient, then you are in more control of the aerosols. Then put on the PPEs and go ahead and do the procedure. That's where we keep ourselves safe and also the cath lab personnel very safe.
True, sir.
Right. And then there's a question here: is COVID-19 curable? Is Yeah, if it doesn't die of COVID-19, it's cured, right? I think that's the way we should probably be doing. We do not know the long terms, no studies so far
Correct.
about what
Yeah.
all has later on to the patient.
In its
And
mild form, I think it behaves like any other viral disease, self-limiting, and probably runs a very mild course. It's only the patients who become sick, we find them, developing complications.
okay. One other thing that I was just thinking was, when you are faced with the ST elevation MI in a suspected COVID, it's good to look at the ECG and fix the territory. Usually in myocarditis, it is never a territory specific ECG that you get. It's a combination of an inferior and an anteroseptal or
Yeah.
Correct.
Yes.
and then
Yes.
something like that. So when you do not get the ST elevation in those contiguous leads which you expect to have, then you tend to go more for a
Conservative.
myocarditis rather than
Yes.
for a fixed.
Yes, sir.
Absolutely.
Generally, ST COVID with T inversion with all V1 to V6 will be there.
Correct.
And
Correct.
echo also will show whether it's a
Yes.
global hyperkinesia
Yes.
or
Yes, sir. Yes, sir. Yes,
a
sir.
regional wall motion kind of an abnormality.
Yeah. Yeah. One of the differential diagnoses is when we were in.
Correct. That's another important point. Another thing Dr. Raghunandan was mentioning was not to handle the non-culprit lesion. When you take the
Correct.
patient to a
Yes.
cath, you don't want the non-culprit lesion to be handled, right?
Absolutely. I
I
think
think
those have been part of the earliest guidelines of primary PCA also, where unless you feel that doing the non-culprit is necessary for hemodynamic or reducing the ischemic burden kind of thing, you would want to actually just do the culprit vessel and stabilize the patient first.
okay, right. So I think it's been a good discussion, and we have had quite a number of questions coming in, and very nice speakers who really enlightened us about the way to move forward when you confront a situation of acute coronary syndrome or a shortness of breath in a situation of a pandemic COVID-19. So thank you, Dr. Raghunandan, and thank you, Dr. Sridhar. I think you have done a fantastic job, and a lot of stimulating questions from the audience as well.
Yeah.
And any last comments which you would like to add, Dr. Raghunandan?
I'd like to thank Zydus for this opportunity, and thanks, Dr. Venkatesh, for that very nice moderation of the whole event today. And congratulations, Dr. Sridhar, for enlightening us about the various aspects of dyspnea in a COVID scenario. Only one caution to all the
I think you're not audible.
Yes,
Something
sir.
with the
Sir, Raghunandan, sir, some audio disturbance is there, sir. Sir, thank you, sir. Thank you, Venkatesh, sir, and thank you, Samir and Raghunandan, sir, and also for the Jidus people. They arranged a nice web seminar. And Venkatesh, sir, I'm nice this thing moderate and nice questions, and discussion was very good, sir. Thank you.
Thank you so much.
Thank you,
Really
thank you,
enjoyed.
sir. Thank you, sir.
It's been really fruitful
Yes, sir.
having a discussion with
Yes,
allied experts. And over to you, Dr. Samir Muchala.
Thank you, Dr. T.K. Venkatesh. I think we had real good deliberations on CVD management, especially keeping the current scenario in mind. My heartfelt thanks to Dr. B.K. Raghunandan and Dr. Sridhar Pedi for their excellent orations. A special thanks to Dr. T.K. Venkatesh for having moderated the session in a manner that the key messages were percolated to our attending delegates. I'm happy to share with you that we have about 780 plus doctors who have witnessed this webinar today across AP, Telangana, and Karnataka. So I thank you all for sparing your precious time, and also thank you for helping our Indian patients come out of this COVID scare. So let us stay indoors,
Dr.
stay
Samir,
healthy, and
before
stay
you
safe.
close, Dr. Samir, before you close, with so many webinars, like, 780, I think is a phenomenal figure. And I congratulate you on getting this kind of an audience, and wonderful work. I know the ground level work has been simply great. And meanwhile, can we just listen to Dr. Raghunandan, because he was saying something and audio got cut. So can we listen
the audio got cut.
from Dr.
Yeah, I
Raghunandan?
just wanted to finally say that as cardiologists now, we should look at a more conservative approach as a first option rather than trying to go into an intervention as a first option. This is the only thing I would say as a cardiologist now we need to change in our approach to handling these patients. The rest of it in managing any ACS would remain the same.
Thank you. Thank you.
Thank
Dr. Samir.
you, sir.
Thank
Thank
you
you,
very
Samir.
much. So let us stay indoors, stay healthy, and good night to all the 850 plus doctors who have witnessed the webinar. Thank you very much and good night.
Thank you, sir.
Thank you, sir.
Thank you all.
Thank you.
Thank you, sir.